All right, we're gonna get started. So we're just going to do cases today and try to discuss, the management of pancreatic neuroendocrine tumors around these cases, and I'll try to get through kind of the textbook answers. But I think PNETs is kind of an interesting thing because the data around it is very bad, and so a lot of the decisions we make are based off of nothing. And so I think there's a lot of nuance to it. So I think that's why the cases will be good to discuss these things. So just standing up and presenting bad data all day is not really something I'm interested in. So, all right. First case, Maria. Mouthful of bagel.
45-year-old woman doesn't have a 1.3 centimeter mass in the body with pancreas on CT with the pain following a childhood.
Okay, so this is like a classic vignette setup. So what are the things you can gather from this so far? Yeah, so if it's a PNET, what kind is it? Yeah, so that's the first thing to divide in your head, non-functional versus functional, right? So what kind of mass does that look like? With that picture alone, you should be able to essentially make the diagnosis. And why? Yeah, on what phase? How do you know that? Yeah, so the aorta is super bright, so it's an arterial phase, right? And then this thing is bright on arterial phase. What pancreas lesions are bright on arterial phase? Don't overthink it. What are we here for today?
Peanuts.
Yes, peanuts, right? So there are very few other things that are that bright on an arterial phase, right? You could have like a hemangioma that's in a spleniole that's in the pancreas or something crazy, but if it's an arterial phase bright pancreatic mass, it's most likely a pancreatic neuroendocrine tumor. Okay. All right. So now if I can get this thing to advance. All right. So read the rest. Did you take another bite of your bagel while you were answering the question? Why would you think that? Have you not been to one of my lectures yet?
Demonstrate cells that stain positively for pomegranate and synaptic.
All right, what does that mean?
Right?
Yes, yes. So those are the classic staining characteristics of a neuroendocrine tumor. So now you know for sure this is a neuroendocrine tumor. We could talk about whether or not that endoscopic ultrasound was necessary, but keep going.
No suspicious lymph nodes are seen. A biochemical workup fails to show the presence of any functional hormone, and the patient is asymptomatic. The most appropriate management would be.
Okay, here are your options.
A, repeat CT scan 3 to 6 months to assess for any changes, surgical installation with denucleation, surgical exploration, distal pancreatectomy, or systemic therapy with sunitinib.
What are you gonna do?
Awesome. 2 7 years Mason track. You do 3 CT scan.
Do whatever you want. But what are you gonna do? Okay. So in all seriousness, as you get closer and closer to taking oral boards, don't answer questions with questions, right? So tell us what you're gonna do, not what the options are. Okay. So chiefs, that's one thing that annoys examiners. Well, you could get a CT scan or you could operate. They know that those options are on the table. Tell them what you want to do. All right. So does anybody disagree with that? Repeat CT scan. Is there any more information that anyone in the audience would want before making that decision?
Any discussion of grade or
okay, good.
Differentiation?
Yeah. So that's one thing that this vignette doesn't give you, right? So you just assume that it's probably well different. What does it look like on the CT scan?
It looks like a well differentiated.
Why?
Because of its degree of arterial enhancement.
Yeah. So what does a poorly differentiated neuroendocrine carcinoma look like?
It would look like pancreatic ductal adenocarcinoma. It would be hypoenhancing.
Yeah. So ductal adenocarcinoma or any poorly differentiated cancer is generally going to be hypointense on an arterial phase. So it looks well diff, but in real life, right, if you had the EUS and you got the biopsy, you would actually get Ki-67. So test what Ki-67 is reassuring. Yeah. Beth.
Less than 20%.
Less than 20 means what?
Is reassuring.
Okay, what does that translate into in grade?
I think that would be like grade 1.
Grade 1 or grade 2. Okay, so the numbers you should have in your mind are 3 and 20. So less than 3 is a well diff or grade 1. Less than 20 is either grade 1 or grade 2, right? 3 to 20 is grade 2. So if your Ki-67 was 19, I would actually say that's pretty concerning. So it's technically less than 20, so it's not high grade, but there's, you know, it's not like these, you know, the graph is not like a direct step off where like 3 to 20 is all going to be the same, right? You have a patient with a Ki-67 of 13, that's pretty concerning. So if their Ki-67 is 2%, very reassuring. If it's like 12, you know, you're kind of creeping up towards the high grade, I would be a little more worried. So I agree that grade certainly plays into this. The NCCN guidelines lump all low and moderate differentiated or basically grade 1, grade 2 together. And I don't really agree with that. So I think as you creep towards higher grade, you're going to be a little more surgically aggressive. So size is really what the NCCN guidelines point to, but there are lots of things that play into it, right? So size and grade, I would say, are the 2 biggest things. And then what's the third big thing? Beth?
Proximity to the gut.
Okay, what does that help you determine?
I think that helps, like whether or not you can enucleate it
Yeah.
versus you have to resect it.
Yeah, I agree. But the other thing I would say is head versus tail, right? So Whipple versus distal, those are 2 different worlds. Those are, you know, very, very different decision trees based on distal versus Whipple. So, okay, so textbook answer, I would say A. But, you know, there are situations where you might be a little more aggressive on this, particularly if this was like higher grade or something like that, you might resect. But the textbook answer is observe anything under 2 centimeters, okay? All right, so now it's 2.2 centimeters, same exact picture. What do you want to do? Maria, back to you. I feel like we just talked about this.
But, okay.
I don't want to know what we could do. I want to know what
yes.
you are going to do.
Sorry, I would do C.
Okay.
After we get a Ki-67.
Yeah, I think that's the textbook answer, right? So if they ask the question on the test and it's over 2 centimeters, you are going to do a formal resection. Why are you not going to enucleate this mass, Ryan?
Make sure you have that margin in case it comes back to anything.
So you can enucleate with a margin, right? So you can get a margin by enucleating. What margin do you need for a neuroendocrine tumor? Even better question. Huh?
So
Yeah, you sure did. You sure did. No. 2 centimeters? No. Further from the truth. 5 centimeters, even further from the truth. You're getting colder. Flynn, what do you think? You just need a negative margin. Yeah, you just need a R0 resection. So it's not quite like a GIST because you do want a true R0, but there's no defined margin. So you can enucleate it, and in reality, these things feel very different than the tissue around them, right? So they feel like these kind of squishy little, like almost like a bouncy ball in the middle of the soft pancreas. So they generally if they're well differentiated, they're well demarcated as well. So you can just enucleate the thing out with, you know, what feels like a negative margin, and you should be fine. So why are we doing a formal resection, a distal pancreatectomy on this patient? Govern, what do you got? Lymphadenopathy, right? So yeah, so lymphadenopathy, I wouldn't use that word, right? Because lymphadenopathy just means big nodes, right? But a positive lymph node. So, and that's where all this size data comes from, these 3 bad papers that say that the lymph nodes are more likely to be positive if you are over 2 centimeters. And it's kind of an arbitrary cutoff. It's based off of 2 single institution retrospective reviews and 1 SEER database study. So these are like not good studies, and the whole field is based on that. So that's why, again, I think this 2 centimeter cutoff, I don't want you to fixate too much on it except for the test. But in real life, we don't necessarily fixate on that. Yeah, go ahead.
Could you also say, I mean, so say you took a more conservative approach, like maybe you'll get that MSK data of observation for less than 3 or 4 centimeters. But,
yeah.
Just in the body or tail, the conservative thing to do is a distal pang.
Yeah.
From a leak standpoint.
Yeah, for sure. I mean, I think that, like I said, I think Whipple versus distal, two different decision trees. So I would agree in this case, in real life, you would probably just go to a distal because it's quote unquote just a distal, right? So if they leak, you know, it's usually a low grade leak that you can manage with a drain. They don't blow out their GDA stump and die, et cetera. So it's just a different decision tree. And so, yes, in real life, I would absolutely do a distal pancreatectomy on this patient. But my point is just that don't be too hard and fast about this 2 centimeter cutoff. Like if it's 1.9 centimeters, but the Ki-67 is 10%, you know, that should push you towards surgery, especially if it's a distal. So that's the point. Questions about any of that? So just to, you know, show a couple things. This is what they look like, right? They're brighter than the surrounding pancreas on arterial phase. And then honestly, it's not the greatest, but it should be basically iso intense on the portal venous phase. And then liver mets are going to look the same way, right? So this patient, this is arterial phase. The liver should actually be hypodense to these tumors, whereas like a colorectal met, that won't really be the case. There may be some enhancement of a colorectal met, but it won't be quite so dramatic as this. And then these are darker on portal venous phase than the surrounding liver. Okay, so that's the characteristic thing of a well-diff neuroendocrine tumor. Okay, so now we're in the head of the pancreas. Okay, so now the mass is over here. It's kind of in the uncinate. Same exact clinical scenario, right? So we're going to keep all the other things the same. It's 1.2 centimeters. It's in the head of the pancreas. What are we going to do now? Give me a med student. This one should be easy after all we've said so far. What are you going to do?
It's under 2 centimeters.
So what are you going to do?
A.
Good. Yeah. So we already did A for the distal. This one, even more, we're going to do A, right? So I do think you'd still take into account the grade and things like that. If it's leaning towards higher grade, you might creep towards resecting. But the bottom line is you should not do a Whipple for this patient. That would be overkill. And the surgical complications don't justify the benefit of that operation. Okay. Yes.
At what point are you going to be pursuing other imaging? You mentioned.
We're going to talk about that. We have a whole hour worth of lecture, and you're jumping right to the
History.
Okay.
yes.
How do you handle the 50-year-old patient with this mass?
Yeah.
Thanks.
Can't handle it. It can't mentally handle this thing being in their pancreas. Yeah, I think that's the beauty of option A, right? Is that you get, so the other thing that we haven't talked about, right? We talked about size, grade, location, proximity to the duct. Well, what we haven't talked about is time, right? So time is your friend in these. So understanding the biology is going to change your decision-making too. So the great thing about option A is that if it grows in 3 to 6 months, you can go take it out. So, and some of that, like, should you do 3, should you do 6? Some of that depends on the patient, I think, how nervous they are and the Ki-67. So if it's a little bit higher Ki-67, I might re-image in 3 months. If it's 2%, I might do it in 6 months, which is an advantage to getting the biopsy. Again, we didn't talk about whether that biopsy was really necessary. And I think the answer to that question is the biopsy is necessary when it's going to change your management. So that's kind of essentially what the NANET's guidelines say is if it's going to change what you're going to do, you should get a biopsy. If it's not, then don't. So if it's 1.2 centimeters, it's in the head, and you're like, I am not doing a Whipple on that, no matter what the biopsy shows, then just repeat a scan in like 3 months. If you're going to determine your imaging window based off the biopsy, something like that, fair enough, get a biopsy. But, you know, an EUS guided biopsy of the head of the pancreas is not without its risk of complications. So you don't necessarily need that biopsy, but I do think it can help a little bit on like how closely you're going to watch. The other option is do 3 months. If it doesn't change, do 6 months. If it doesn't change, then stretch them out to a year. And then, you know, a 50-year-old is tough because is that thing really going to sit there for 30 years and not grow? The answer is actually maybe, you know, so there are some of these where they really don't grow for years and years and years. So I think that's why observation is the right answer. The other thing is that, you know, if I was going to have a Whipple, I'd try to push it off as long as I could, just because, you know, the rest of your life, you're going to be dealing with some level of not normal tolerance of diet and things like that. I mean, people get pretty close to normal, but quality of life definitely goes down after a Whipple. So if you can avoid it for a decade, you probably would want to. Yes.
Speaking to that, sir, do you ever consider though, like that functionally people get worse over time? And so someone at
Sure.
like age 60 would be able to tolerate a whipple, whereas at age 70 they would not.
Yeah, I think that's fair. Now, if they were 60 and they were going to make it to 70, then at 70, even if it hit 2 centimeters, you're like, what are we really doing here? Because what's the 10-year survival of a patient with a metastatic, well-differentiated neuroendocrine tumor?
Still high.
What do you think it is?
I believe it's 65.
Yeah, I would say around 65, 70%. Yeah, exactly. So 2/3 of patients who you need to do a Whipple on at 75 are still going to be around at 85, and they're probably going to die of something else. So something that you've watched for 10 years and now they're 70, 75 and they're a bad surgical candidate because they're on, they're about to be on dialysis or whatever, you're not helping them by doing them a Whipple, by doing a Whipple at that point anyway. So again, I just think that these are incredibly nuanced. And so you have to think about all these different things. There is that argument that like, if you're going to need a Whipple, you'll do better with it now. But I just don't love that argument in something where you've already watched it for 10 years and it's barely grown and it hasn't developed any nodes or whatever. So, all right. 2 points. What do we say? 1.2, you're going to do A. Okay. Here's the NCCN guidelines, right? So we're going to talk about the different imaging things in a second, but basically get a CT or an MRI. And then they basically break it down if it's local regional and less than 2 centimeters, but then they give you all the options, right? So it's like the NCCN guidelines are so worthless here, and the NANETS guidelines are more nuanced, but they're not much better. The only difference is that under 2 centimeters observation is an option. And so that's the test answer, I guess I would say. But over 2 centimeters, the test answer is always formal resection with lymphadenectomy. Okay. Now in real life, again, much more nuanced. All right, so now it's 2.2 centimeters in the head of the pancreas. Test answer is going to be yes, non-functional. We're going to talk about functional after, but yes, this is all for non-functional. 2.2 centimeters in the head. What are we going to do? Yeah, so we have to do a Whipple because we got to get nodes, right? So you can enucleate that 1.2 centimeter mass if, what's the big if on enucleation? Yeah, proximity to the duct. Yeah, who knows? I don't know. It's like, it's kind of an eyeball thing. Do you think you can see it? The other problem, right, is that patients with an absolutely normal pancreatic duct, sometimes it's really hard to see the pancreatic duct. And that's one place where I think MRI is probably better than CT, is that if you get an MRCP, you can almost always see the pancreatic duct. But the problem is on the MRCP phase, you can't always see the pancreatic neuroendocrine tumor. So then you have to take the T1 arterial phase and the MRCP and put them together in your head and try to figure out the proximity to the duct. But yeah, I think, there's no magic cutoff for proximity to the duct. It's just whether you think you can bovie that thing out without damaging the duct. 2 millimeters sounds really tight to me. I would probably go a little bigger because, enucleation, and we can talk about, so let's go back to, what's the other option we haven't talked about for something in the neck? Like this thing. What else could you do? What other operation could you do for this patient? Central pancreatectomy, right? So that is also an option. Why would you do a central pancreatectomy?
If you thought that, perhaps someone's kind of a marginal surgical candidate, they would turn into a very brittle diabetic, for instance, if you did a Whipple.
Okay.
Or
So
if you,
why would their diabetes be better? That's
after a central versus a
yeah.
Whipple, just in terms of maintenance of more pancreatic.
Right. So pancreatic parenchymal preservation is kind of the term that they use. So when is it really important to try to preserve pancreas in the world of PNETs?
Or if you have someone that has a familial type and you think that you're really operating on a field defect, then maybe you have to go back.
Right. So familial pancreatic neuroendocrine tumors are a slightly different beast because the recurrence rate is so high. And so in those cases, preserving pancreas is kind of the big goal. So that's where people push more and more for enucleation, right? And they might do a central pancreatectomy. A central pancreatectomy means you basically do a distal and staple off over the neck, and then you go over here and you either staple off and leave some tail that's undrained, or you have to do a PJ. And so the problem with doing a central pancreatectomy is what complication goes way up when you do a central pancreatectomy. Leak, yeah, leak. So you have two places to leak from, and the reality is that a PJ to the duct out in the tail is like the hardest PJ to do because the duct is smaller. And these, one of the things about neuroendocrine versus PDAC. So in general, if you do a Whipple for neuroendocrine versus PDAC, who's going to leak more often? Intern. Jamie. Neuroendocrine, sure. Why? Two things that determine your leak rate after a Whipple. The third thing is how many stitches you put in the duct. Nope. So you're doing a Whipple, right? It's basically the same operation no matter where it is. It's in the Unson end of the head or whatever. What's the two things that determine the leak rate? Two most important factors. Beth.
Sure, texture and duct size.
Yeah, so texture and duct size. So pancreatic neuroendocrine tumors have what kind of pancreas? Soft, and their ducts are small. So pancreatic ductal adenocarcinoma starts in the duct. So it obstructs the duct. So the duct gets back pressure, the duct gets big, and the pancreas gets firm, right? There's always some element of pancreatitis in a patient with pancreatic ductal adenocarcinoma. Not true in neuroendocrine tumors unless it is true, right? So there are some neuroendocrine tumors that just happen to, bless you, that just happen to occur right on the duct, and they'll obstruct the duct, cause pancreatitis, et cetera. And then you're like, oh, good, this pancreas will be firm, the duct will be big, blah, blah, blah. But in general, the pancreatic neuroendocrine tumor, the whole equation changes a little bit because the leak rate is much, much higher. So, and then what's the third factor that determines your leak rate? The amount of stitches, exactly. Technical. No, patient factor. Nope. Obesity, yes. So BMI is probably the third most important factor. Which neuroendocrine tumor patients are obese? Insulinomas. So insulinomas are like the scariest Whipples, right? So if you have an insulinoma and you have to do a Whipple, be very afraid because their pancreas is soft, their duct is small, and they're generally very obese. So their leak rate is astronomical. Almost every, I don't know, 60, 80% leak rate. And they're usually bad leaks. They're long-term leaks that cause lots of problems. So anyway, all that to say, it's just a little bit different equation when you're doing a Whipple for PDAC versus PNET. And then for a central, the same is going to be true. If you have to do a PJ out on the tail of the pancreas and a tiny duct and a soft pancreas, leak rate is going to be 60, 70%. So central pancreatectomy, not good. Go ahead.
Why is it that obesity is a risk factor? I understand the
Yeah, there's fatty replacement of the pancreas, so it makes the pancreas uber soft. And then also it's technically harder to do a Whipple on a fat patient because you're in a deeper hole, and throwing the stitches in the PJ is one of the places where that really matters. Is when you're very deep, it's very difficult to kind of hook the duct and get those stitches in. So I think those are the two factors. All right, I don't know what we were talking about. Central pancreatectomy is an option, but it's not a good one. But if you have a patient with familial PNET and it's right on their duct in the neck, you might do a central pancreatectomy because you can't enucleate and you want to preserve pancreas.
Can I ask a follow-up question?
Yes.
The decision making between bringing up the bowel versus doing
Who knows? That's like way in the weeds. It would be, I would say depends on how much pancreas you have left. So if some obese patients have like wispy pancreas in the middle of this fat and there's like very little functional pancreas, I would just staple that off. If you were leaving 2 centimeters or less, I would just staple it off. But if you're like doing a central right at the neck and you're leaving this much pancreas and there's a duct to sew to, then I'd probably do a central. I've never done a central. I hope I never have to. It's not a good operation, but it is an option. All right, did we beat that horse? Okay, what if you're on the fence about whether to resect? How do you know whether or not the nodes are positive? What are your options? If you have like the common hepatic node looks a little big, what are you gonna do about that? Yeah, you saw the slide. Now, so you can do a DotaTate slide. What's the other option? There's another option. They're already in there doing their endoscopic ultrasound. Yeah, they can EUS biopsy in there too. So, but if you're kind of on the fence, that might be one thing that tips you over the edge. Is you see a node that looks a little big, especially if it's a distal, I'd probably just do it. If it's a Whipple, then you kind of want to know for sure whether or not those nodes are real. So there are additional imaging things that you can do. The other time that this comes up is if you're kind of on the fence about whether or not it's a neuroendocrine tumor. It doesn't classically light up on the arterial phase, you're sort of not sure, then a DotaTate can be helpful. The problem is right now, honestly, we don't actually know when DotaTates are helpful. So these studies are not really done yet. So what's the sensitivity of detecting nodal mets with DotaTate, Alex?
Probably between 80 and 90%.
That's
but I don't think
completely made up. Nobody knows.
Yeah, that's a number for
Yeah.
the
Right, that's the problem, right? So, but the primary tumor is often bigger. Now, that's true for pancreas, not for small bowels. I don't want to get too into the weeds here, but nobody really knows what the sensitivity for nodal mets for a DotaTate is. So people do this. They're like, well, I want to know if there's positive nodes. I'm going to get a DotaTate, but that's based on their nothing. That's based on their suspicion that it might work. And these are very expensive tests. So, whether or not that's justified is questionable. So there are two kinds of specific imaging you can get for things that have somatostatin receptors. So what are the two types? Arteria scan and DotaTate. How does an arteria scan work? Huh?
So, it's somatostatin analog.
Yeah. What kind of scan is it?
Stack.
Yeah, it's SPECT. So the somatostatin receptor scintigraphy, or the arteria scan, this is the old thing. How many of you have seen an arteria scan in the last 4 years? Good, because they're no longer done anymore. So it's really for historical interest only. So the key things is this problem. So it doesn't pick up all the somatostatin receptors. It specifically only picks up 2 and 5, and Insulinoma express type 3. So that's that might be on your AB site potentially, is that arteria scans are not sensitive for insulinomas. But now the new generation, which is, so this is what they look like. This is with SPECT CT. The old school thing was you would get that like body, with like the SPECT things that light up. It was more like a scout image, but now we actually have SPECT CT. So it's pretty good, but PET CT is a little bit finer. So everybody's gone to DotaTate. So I talked about the receptor type. The other big advantage of this is that it's PET, and people just like PET better. So essentially the magic of this is you have this chelator that you can plug basically anything into and then add a peptide to. So this technology can be used for lots of things and probably will in the future, but it's found a home with somatostatin receptors. So this peptide is a somatostatin analog, binds to the somatostatin receptor, and then gets taken into the cell, and then it lights up the cell. So this can be an imaging payload or a therapeutic payload, right? If it's a therapeutic payload, what's that called, Bobby? Lutathera, yeah. So the imaging one is gallium-68. The other one is indium something, I can't remember. But Lutathera is basically the exact same model, but that radioisotope kills things. Okay. So this is what it looks like. This is kind of the old school scout SPECT image. This is what our PET images look like now. People like it better because PET is better than SPECT. Okay. Makes sense. The other thing that's nice about it is that it's predictive of Lutathera efficacy, right? So if you light up on DotaTate, then Lutathera should work to kill your tumor. Make sense? All right, this is kind of a cool little diagram I found in a paper yesterday that I like. So let me introduce it for a second. So if you have a high-grade neuroendocrine tumor, Dave, what imaging do you think it will light up on? Will it light up on DotaTate? So the Ki-67 is 23%. Yeah, why? Yeah, they lose the somatostatin receptors, right? So yeah, as they de-differentiate, they become less and less like normal neuroendocrine cells, and they lose the somatostatin receptors. So they will light up less and less on DotaTate. And then what will they actually do now that you can utilize for imaging? Yeah, what does PET measure? Yeah. Right. So it's metabolic activity, right? So it's just tagged glucose, you give it through the IV, and then cells that are going crazy light up. So, you get lots of false positives on PET, like from the heart, you get kind of this baseline liver level, the bladder, all these places where there's lots of metabolic activity will light up, but tumors will also light up. So this figure I thought was kind of cool. So functional imaging, so kind of the more well-differentiated moving towards neuroendocrine carcinoma, which is bad, and then you kind of have in the middle. So the more well-differentiated, the more DotaTate will light up. The worse differentiation, more dedifferentiation, the more PET will light up. And then in the middle, you're kind of stuck with both and see what happens. But what's cool about it is that it's sort of, it predicts what will work, what therapies will work. So if they light up on DotaTate, we talked about it, PRRT, which is Lutathera, will work, or you can give somatostatin analogs, right? Because they have a lot of somatostatin receptors. Somatostatin analogs will keep the tumor at bay and control their symptoms if they're symptomatic. And then if you get down to neuroendocrine carcinoma, the only thing we really have is platinum-based chemotherapy. And then in the middle, you sort of like, who knows? So this is a nice strategy for these kind of in the middle ones. If they're not resectable or whatever, and you want to treat them, how are you going to treat them? Are you going to give them chemo, or are you going to give them somatostatin-based therapy? So you can use the two imaging, the two PET scans, FDG PET versus gallium PET. And if they light up on gallium, give them the somatostatin. If they light up on FDG, give them chemo. Make sense? Okay. All right. Larger than 2 centimeters, you got to get a lymphadenectomy. Okay. All right. Tess.
66-year-old presents with right over the abdominal pain as CT scan demonstrates massive head of the pancreas accompanied by diffuse involvement of the liver. With bulky tumors that enhance the arterial phase contrast, evaluation of biopsy specimen from one of the lesion indicates a well-differentiated neuroendocrine tumor. Which of the following therapies is most likely to palliate her symptoms?
All right. So this lady has a well-diff neuroendocrine, but tumors all over, and you want to palliate her symptoms. That's the key to the vignette. What do you think will work best? Yeah. So once they throw the word symptoms in, then the somatostatin analog. Now it's interesting in this case. I think it's a bad question, sort of, but I stole it from SOSAP. But why does she have right upper quadrant pain? Maybe because of the bulk of her tumor. And in that case, you might get a little more aggressive. But so the point of this question is, what are the options for metastatic disease and well-differentiated neuroendocrine tumors? So talk me through the options that you know of. Some of them are listed here. Okay. Any idea what names those are? How are they? What are the names of those products? Beth.
I think we use lanreotide.
Yeah, lanreotide is probably the one we use the most. And all that is long-acting somatostatin. So somatostatin LAR is the other name for that. And so it's injected once monthly. So have any of y'all given that before? So Alex, how do you give it? What do you do?
Usually,
You just give them a month dose and send them on their way, or?
Oh, no, I've not administered it myself, I suppose, but I'm just thinking of like the side effects in terms of people are GI upset.
Yeah.
Diarrhea.
So how do you figure out whether or not a patient's going to have that symptom before you give them a month-long dose?
You can give them a trial dose of short-acting.
Yeah.
Just not treated.
Yeah. So that's probably the learning point there. It's just don't give them the month-long dose without any test run. So how long does octreotide last? How do you dose it? Any idea?
TID, so 8 hours.
Yeah, roughly. Yeah. So you give it TID. So I usually give them 2 or 3 days of TID dosing and see if they do okay. What symptoms are you looking for? McGovern. Let's go McGovern. From the octreotide? Annie, what do you think? What do you mean by GI upset? So flushing diarrhea you get with what? With the tumor, right? So the tumor makes them have flushing diarrhea. This medicine is meant to negate that. So what do you think you get? So there's a really easy way to know what you get. Because what does a patient with a somatostatinoma get? Beth, what do they get?
Lithiasis.
Yeah.
I just need to like shut it.
Yeah, so they get diabetes. And then the other thing that happens is they get kind of like crampy pain from almost like an ileus. So some patients will get sort of the GI upset is not diarrhea, but the opposite. They'll get constipation and just kind of some crampy pain. So those are the things to watch out for. It's actually not very common that they get them. And so not everybody even gives the test dose, but and the same thing if you're treating a symptomatic carcinoid tumor, you can use the same drug. So usually give short acting octreotide for a little bit, see if it works, and then give the long acting.
What is the time frame for looking at those symptoms?
Usually it's pretty immediate, like they feel it like within a half hour once they get the medicine. So I've had one patient really complain about symptoms, and I warned him, and I think I shouldn't have warned him. I'm not sure. Anyway, so don't warn them too much. And then the other things, what's sunitinib? What kind of class of drug is that? Anybody know? Anybody? Yeah, TKI. So there are a couple of TKIs out there that are also used for pancreatic neuroendocrine tumor in the metastatic setting. Everolimus, sunitinib. I think those are the two big ones. So here's the NCCN guidelines. I'll direct your attention to this list over here. And the point is, what is the point of this giant list? Yeah, you can do what you want. There's no specific answer, right? So they have TKIs listed. This, what is CAPE-10? Anybody know what that is?
The salvage chemotherapy.
Yeah, systemic chemo. So you can give chemotherapy for these. Again, the higher the Ki-67, the more likely that chemo is to work. This is the preferred combination, CAPE-10. What do you think the response rate for a grade 1 or grade 2 neuroendocrine tumor is for CAPE-10 in the phase 2 study that's been done? Is it high or low? Low. How low? 30%. I don't know who said that. Did you read the study?
Yes.
That's excellent. Good preparation. But yeah, so about 30%. So if you had a 30% response rate in something that for like neoadjuvant therapy, that would be very bad, right? So it will keep some more at bay, but the response rate is very low. So do we ever try to get a response out of these tumors because they're unresectable or they're like borderline resectable? The answer is yes. It's just not very successful. And then this is my other favorite thing from the NCCN guidelines. Currently, there are no data to support a specific sequence of regional versus systemic therapy and no data to guide sequencing of systemic therapy options. That is the take home for metastatic neuroendocrine tumors. We have no idea what to do, throw some stuff at it. So the other thing I think you should know about the somatostatin analogs and the TKIs. So the studies of lanreotide, everolimus, and sunitinib, they all showed one common thing in the outcomes. There's progression-free survival and overall survival. What do they do, Liv, since you've read all these studies? What do they do to progression-free survival? What do they do to overall survival?
I don't think they change
Right, so they help progression-free survival. They do not necessarily change overall survival. And that's probably because every patient that progresses then gets some other drug, right? One of this list of drugs, and then their progression gets halted by that. So what does that tell you about the timing of these options? One of the med students said it, yeah. Doesn't matter. So when we resect a pancreatic neuroendocrine tumor, and it's, let's say there's 5 out of 7 positive nodes, and you're like, that thing's coming back, no question. But they're currently NED. What do? You start them on the lanreotide? No. Yeah, you just wait till they recur. So there's no indication for adjuvant therapy for neuroendocrine tumors. So you basically just sit tight and wait, and then when they recur, you start treatment. Right. And then what will happen is you'll give them one drug, and they'll sit tight for 2 years. And then all of a sudden they'll start progressing. And then what do? Go down the list, right? Just keep going down the list. And then eventually you get to like PRRT is probably kind of like the last thing that we often give. The reason that we don't give PRRT up front is because there's real toxicity to it. The TKIs have some minor toxicity. The somatostatin analogs have very little toxicity, minus the GI upset and maybe gallstones. But the PRRT has one very well-known bad toxicity. Any idea, Beth? I think we may have covered it in our one. Yeah. It's okay. You don't have to tell them that you're cheating. What is it? Yeah, so they can get essentially bone marrow malignancy. So we save PRRT until we really need it, is kind of the bottom line. But anyway, lots of options, whatever.
How is PRT given? Like, is it how frequent? And
I actually don't know the answer to that. Monthly or? I think they have like a set dose, right? And then they like divide the dose up, and then they decide based on volume of tumor and how they light up on the gallium study. Like how, I don't know, honestly. You send them down to NucMed and they like do some calculation. Yeah.
In the NET trial, we got up to 4 doses. So the whole treatment course is kind of.
Yeah, one of the things I find is that they're not followed, they stay on a K-type for so long that people stop paying attention very much. And then they present with an obstruction, and then we do some sort of palliative surgery, and then, I mean, this has happened to me several times anyway. And then I'm like, we need to do something different, because like they're gonna obstruct again, and then they sort of struggle through the PRT, sort of like hoping that will be a response, as opposed to stopping progression at that point. That's not really.
Yeah, I do think that people are they're studying PRT in lower volume, like earlier disease, but they, for now, the indication is generally late disease after other things have failed. But as the NCCN guideline, who knows? So maybe someday we'll give in PRT much earlier.
There's a couple, I guess it's still a case series where you're using it almost like an imaginary thing for someone.
Yeah.
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 I'm trying just to kind of show how try doing that.
Yeah.
Like in the mesentery before they obstruct.
Yeah, I think the hard thing about, like, I'm thinking about using it neoadjuvantly, it's radiation. So if you better like use it just right and catch the window just right, because otherwise what you've done is radiated the mesentery basically, and now you're going to try to like dissect out the SMA and save it in this radiated field. So probably you'd want to kind of keep to that 4 to 6 week window after PRT. But that is one of the concerns, is that it does have some detrimental effect to normal tissue around it.
then, sorry, just a follow-up question. You guys talking about people netting out, like to the liver into the mesentery, is that your two?
So we're kind of mixing things, so I don't want you guys to get confused. That when you talk about small bowel neuroendocrine tumors, what do those patients die of? Huh? No. Obstruction. So small bowel neuroendocrine tumors have this weird phenomenon where a very small tumor can create a very big mess in the mesentery with lymph nodes. So we're very surgically aggressive with small bowel neuroendocrine tumors because you got to go get the lymph node nets out before basically they make this big desmoplastic ball of cancer and all the bowel gets sucked into it. So while they're treated the same, these treatment options are all on the board for small bowel versus pancreatic. The way they present and the way they die is very, very different. So a pancreatic neuroendocrine tumor, I don't really worry too much about the consequence of the nodal disease. Those patients die of metastatic disease, usually in the liver, right? So their liver gets replaced with mets eventually, and that's what they die of. Small bowel neuroendocrine tumors, it's the nodal mets are the problem. So it's two different phenomena. Okay. All right. Okay. Back to the interns. Jamie. We're going to go through just quickly some classic things.
I mean, for this person in this context, worried about.
Yeah.
Start with, I mean, you don't have any imaging, but you can start with that. And also check for.
So what basic tests are you doing? I'm in the lab right now. What are you gonna get?
I'll just get like there's a BMP for electrolytes since they could also be super deranged, but an insulin would be.
Insulin, glucose, right,
glucose.
at the same time, and C-peptide, yeah. So just be aware of the abside question where if the insulin is high and the glucose is low, you're thinking insulinoma, but if the C-peptide is low, what is it? Yeah, they're just crazy and they're giving themselves insulin. So just be aware of that abside question. Is that word canceled? I'm not allowed to say that word. Can't say that. All right. So if the labs are equivocal, though, you send them down to the lab and kind of get some meh numbers. What's the gold standard for this? You're basically going to send the same labs, but first you're going to do what? You're on the right track. just going to have them fast more. So you're going to admit them for a 72-hour fast. And then I think there's a couple of reasons you admit them. One, it may be very dangerous for this patient to fast for 72 hours. So if they become symptomatic in the hospital, you're going to check the labs then, and then it should be obvious. But the other thing is, I think it does get into that surreptitious thing where you want to kind of watch and make sure they're not doing something silly. Okay. So high C-peptide, we already talked about it. That's them doing silly things. All right. And then now what are we going to do? After we have the diagnosis secured, we got to do what?
I would get imaging to see
Yeah.
if they have just like one.
Okay, so they have a mass. What are you gonna do?
Well, I think with insulinomas.
Yeah, good. So that's probably the right answer. So if it's in the tail, I would probably do a distal. But if you can enucleate, if you can save pancreas, it's probably the right thing to do because they're often multifocal and they'll come back. So I think there's like a patient that we have out there, endocrine following, who got a distal and then got like an enucleation, right? That lady. Yeah, and then now she has another recurrence and she needs like a completion pancreatectomy. Yeah, that's what. Yeah, so she got like a 1 bite, 2 bites, and now she's recurred in what's left of her pancreas. And a total pancreatectomy is a nightmare, but so is having an insulinoma. But they're almost the same disease in some ways. So she's like currently being managed well by endocrine. So it's like, you know, what's the point? If we take the rest of your pancreas out, yes, you won't have an insulinoma anymore, but you'll kind of have the same problem still. You'll still need like crazy glucose control and you'll go up and down. So anyway.
I feel like you heard, it's interesting. In that case, the biggest issue is weight gain.
Yeah.
Which makes it later out later.
Yeah. And that is one thing about insulinomas that's a little different, is that they very rarely metastasize. So you're really dealing with the symptoms of the disease, less so the metastatic disease, the metastatic component. So you're like, should we operate to prevent metastatic disease? Maybe, but you know, insulinomas tend to be more, quote, benign. Like when you study for the ABSITE, they'll tell you insulinomas are benign. I really don't like the terms malignant and benign in these because it's really just indolent versus aggressive, but eventually they can all spread. And, you know, so I don't like, those terms don't make any sense to me in this disease, but they're frequently used.
I had a conversation for about 30 minutes. And it's on Thursday. This is lung cancer.
Right.
Just for 1 point more than a week.
Right. Yeah. The answer is yes, sort of.
So does a biopsy change like?
Of insulinoma?
Yes.
Yeah, it's a good question. I mean, I guess the problem is that insulinomas are very symptomatic when they're very small. So like in her case, I think she doesn't even look like, you're not even exactly sure where it is. You're just like, well, if we take out the rest of the pancreas, we got to get it, you know? So that's the problem, is that it's hard to US biopsy these because they're very small. I mean, this is not the most realistic situation where you have a 1.2 centimeter tumor. A lot of times you'll barely be able to see it. And this is actually a great indication for DotaTate. So I think that's one of the reasons that we switched from Octreoscan, is because one of the main times you actually need the imaging is an insulinoma, and then Octreoscan didn't work for insulinoma. So this is a good indication for DotaTate because it'll show you things that you may not be able to see on the CT scan. But
if they have this and they have 2 areas of light up in the liver.
yeah, that's a bad problem. So yeah, so should you take the primary out in the setting of metastatic disease? That has been studied in poor form also. So there are retrospective studies that say if you operate on patients with metastatic disease, they do better, but they're all retrospective big data. So operation leading to better survival in big data should be the expectation. So anytime you take a retrospective analysis where there's highly selected operations, right? So the surgeon is choosing who to operate on, who not to operate on. The people who get surgery will always live longer. So that's kind of meaningless data. But there have been other papers that look at symptomatic or functional neuroendocrine tumors. If you can take out 80 to 90% of the bulk of the tumor, those patients will do better. Their symptoms will get better and they will live longer. So if you have 2 liver mets and you can get all of it, I would say yes, operate, with the knowledge that it's going to come back at some point. If you're doing a Whipple in that setting, I would say that's probably maybe not the right answer. So like doing a total pancreatectomy in a patient with metastatic disease, I don't know about that. But if the patient's like horribly symptomatic and their life is miserable and they want to go for it, reasonable. Okay, what if it's in the head and you need a Whipple? You try to enucleate, and then, so this is one tricky thing about DotaTate. So CT is negative, and you get some DotaTate signal in the uncinate. Any of the chiefs have any thoughts on that?
Means that someone should try like the neoadjuvant fludarabine?
The point of me putting that is that it's a very common false positive. So the uncinate almost always lights up on DotaTate. So just be very, very careful about operating on something like that. In that case, I would probably go to EUS and try to find a correlate, because the uncinate is notoriously falsely positive on DotaTate. So just be careful. Nobody knows. Magic. There must be a lot of somatostatin receptors in the uncinate. I don't know. All right. Okay, so this lady has an ulcer. She gets treated and she still has an ulcer. What should you think? In the midst of the neuroendocrine tumor lecture, Gastrinoma, right? So, okay, so she's on a PPI and her gastrin level is 1100 and her pH is less than 2. What do you think? Yeah, it's Gastrinoma. So we're going to go kind of quick here, but the diagnostic criteria are anybody with a pH less than 2 and a gastrin level over 1000 has a Gastrinoma, unless they have this syndrome, this post-operative syndrome. They had a surgery for ulcers in the past. Yeah, retained antrum. Explain what retained antrum syndrome means. Any of the interns know? Bonus points? You get an extra bagel. Nobody knows. Talk to me about it. I am talking about that, but I'm going to need more details than that.
Their stomach continually produces gastrin.
What stomach? They got their stomach removed already.
Yeah.
But their antrum was
They had an
removed.
antrectomy, but
And an antrectomy of B2 for ulcer disease 5 years ago. How are they making gastrin?
There's some that's still left.
Yes.
Like most of them was missed.
Yeah, exactly. So,
Producing gastrin and the feedback loop is destructive.
right. So like when we do a total gastrectomy, a lot of times we'll send a frozen of the distal staple line to make sure that they see duodenum. So we're sure that we got it. But if you know, I mean, they used to do crazy things, right? But no, if you just miss basically, right? You like feel the pylorus and staple and you think you're past the pylorus, but you're not, and you leave a little bit of antrum. That antrum is now bathed in duodenal juice, which has what in it? What does the pancreas squirt into the duodenum constantly? Bicarb. So you have antrum that's bathed in bicarb, and it's just going to drive your gastrin level through the roof, and then you make acid. Usually that presents with what? Where would they get an ulcer? In the duodenum? The duodenum is no longer connected to their stomach, so they're not going to have acid in their duodenum. Where do they get ulcers? Yeah, their B2 reconstruction. Letter name. Beth?
I guess it's jejunum, is that?
What part of the jejunum?
Oh,
There's a specific name for this type of ulcer.
I don't know.
someone with B2 and
Flynn, marginal, marginal, marginal. So they get an ulcer at the jejunum that's sewn to their stomach because they have tons of acid being made by the stomach, and they have this piece of jejunum right next to the stomach that shouldn't be next to the stomach, right? So that's the common presentation is recurrent marginal ulcers after a B2. You need to think retained antrum, check a gastrin level. So a retained antrum will have a very similar, very high gastrin level with a low pH. But those are the two things that can cause this finding. Okay. What if it's equivocal? What are we going to do, Maria? So gastrin level is like 200. It's high, but it's not that high.
Right, as if we submit,
Yeah. And what should you see?
paradoxical increase.
Yeah. Yeah, really the diagnostic criteria are just that it remains elevated. So that's the teaching, is that it actually goes up, and maybe it does most of the time, but the diagnostic criteria just are that it should be over 100 after secretin. So that's a gastrinoma. So what are you going to do now? You're going to localize it first, right? So get imaging to localize it. The other weird thing about gastrinoma is gastrinoma triangle, which is what? Cystic common. Second third of the duodenum. Yeah, and head neck of the pancreas. So in that triangle is where gastrinomas are found. If you don't see it on imaging, What is the described maneuver, Liv, to find it?
Go for it.
How do you feel for it? So you do a coker, you're feeling the head of the pancreas, you still don't feel it.
Intraoperative ultrasound.
Don't find it. Close up shop. Close up shop. Go home.
Oh, you can open up the July.
How would you do that?
I would do, my, after my.
Right.
Do a longitudinal incision on the abdomen and look at the ambulance.
You're gonna look at it.
I'm gonna feel it.
You're gonna feel it. Yeah. So the described maneuver is longitudinal duodenotomy on the lateral side. Put your finger in, run along the medial side of the duodenum, and you'll find, I don't know, every single neuroendocrine tumor ever. So.
But how do you like differentiate that between the ampulla? You know, it's gonna feel like a little nipple.
With your eyeballs, I think. I don't. Yeah. So you would look and make sure you're not going to whack out the ampulla.
Do you think that's?
That is the described maneuver that you should all be aware of. But has anyone in our generation ever done that? Maybe not. But it's this very well described thing that all surgical oncology people love to talk about. So it'll be on some test somewhere someday. All right. What's this? Yeah. Which is caused by? Yeah. Okay, good. I think I'm done.
You mentioned why that happens, and I still have.
Oh yeah, that's my favorite thing, because if you remember that, you'll actually understand how to treat it. So how do you treat it? Why? Why? I mean, you know the treatment, but you don't know why. Perfect. Yeah. So you're basically making everything into glucose, everything into glucose, everything into glucose, which includes all your amino acids. So you lack essential amino acids. So if you admit this person, put them on an essential amino acid infusion, they will get better like that because they just lack amino acids because they're turning all their protein into sugar. That's it. All right, Montana. Questions?